Welcome, everyone. Good afternoon if you're on the East Coast by 1 minute. My name is Will Blesser, and I am Research Director of Healthcare Transformation for Social Needs and Health Equity here at the Duke-Margolis Institute for Health Policy. We're really excited to have you here. This is a really critical time in health policy for health-related social needs, right? North Carolina has now delivered about 500,000 health-related social needs services through the Healthy Opportunities pilots, their Section 1115 Medicaid waiver program, which is now about 2.5 years into service delivery. And with CMS recently releasing their health-related social needs framework in the fall, and other states getting ready to launch models similar to North Carolina's like New York, and Medicare, as of this year, is now paying for community health integration services, we know that everyone is really anxious to hear about North Carolina's work. So for today's goals, we're going to reflect on 2.5 years of implementing the Healthy Opportunities Pilots program. We're also going to delve a little bit into the present, some complexities with health-related housing service, payment, and delivery, and we're going to discuss the future of the program, as well as more of a statewide approach for addressing health-related social needs in North Carolina, beyond the pilots and nationally. Just some quick housekeeping. We are excited to announce this webinar will feature some real-time Spanish translation via next-generational artificial intelligence speech translation. For any attendees who would prefer to listen to this webinar in Spanish, click on the link that was just posted in the chat and select Spanish from the language dropdown, and Zoom closed captioning is also available. I wanted to mention that we'll do questions at the end of each panel if time allows from the audience, so participants should direct their questions into the Q&A box and we will monitor that. And lastly, the meeting is being recorded and we will post a recording within a week or so after the event. Next slide, please. And one more, perfect. I just wanted to note, just this week, we released a new practical evidence-based guide for community care hubs nationwide who are interested in starting, scaling, and sustaining work to address health-related social needs. And that is available by the link that we're going to drop in the chat, and we would encourage you to read that. It's meant for community care hubs who want to do this work. And with that, I'm going to transition over to my co-host, Michelle Reese.
Thank you so much, Will. And on behalf of the North Carolina Institute of Medicine, thank you to all our panelists today and to the attendees for joining us today as well. For those of you in North Carolina or from across the country who are unfamiliar with the North Carolina Institute of Medicine, just a bit of background. We serve as a neutral convener and as an advisory organization in our state, and we make recommendations to state and local policymakers and practitioners about how to best address health policy and healthcare challenges that they're facing. And we also serve to connect stakeholders with research, data, and diverse perspectives that can inform their work. We're so grateful to Duke-Margolis for our amazing partnership and for the opportunity to bring lessons and data about the Healthy Opportunities pilots to you today. We're very proud of North Carolina's innovative approach to improving health outcomes through this way of directly addressing non-clinical drivers of health. And we're really excited to share the perspectives and the experiences of today's panelists. So thank you again for being here. I'll turn it back to Will now.
Wonderful. Click to the next slide, please, and we're going to get ready for our first panel. So it's really my pleasure to introduce the following 4 panelists that we're going to hear from. We're going to talk about, again, looking backwards, the last 2.5 years of implementing this program. So with us today will be Seth Berkowitz, Associate Professor of Medicine at UNC Chapel Hill, who's also leading the CMS evaluation of the pilots program. Tina Dixon, the Vice President for Healthy Opportunities of Access East, one of the community care hubs implementing the program. Crystal Howard, the Whole Health and Health Equity Director of Healthy Blue, one of the prepaid health plans implementing the program, and Amanda Van Vliet, Director of Social Determinants of Health at Highmark Health, also formerly was leading this program at NCDHHS. So please welcome my panelists and we can pull down the slides. Wonderful, I see everyone. Amanda, I wanted to kick it over to you to start. Right, this was a big program that involved a lot of key communications and then balancing that with a lot of tactical details. Could you talk briefly about the high-level vision of the pilots at the beginning, how you communicated that across the aisle, and how did you tactically make this a reality? I know a lot of Medicaid folks are listening.
Yes. First, thank you so much for having me. It's really nice to be back among friends and colleagues. Hopefully I can do this justice. I'm glad that Deputy Secretary Loveland is on, who can add to this. But the original vision for the Healthy Opportunities pilots really arose from the broader concept of using the transition of Medicaid from fee-for-service to managed care to address whole person health. So the department wanted every health plan to address physical health, behavioral health, and non-medical health like food, housing, and transportation. But non-medical services, as we know, hadn't traditionally been covered by Medicaid for broad swaths of populations before. So we knew that we would need CMS authority to pay for non-medical benefits, but we'd also need to create the infrastructure and relationships to support that. So at this time, North Carolina had a Democratic governor, a Republican-led legislature, and was negotiating our 1115 waiver to do this work with the Trump administration. So we worked with the Trump administration to get our waiver approved. My understanding is by focusing on covering non-medical benefits that had an existing evidence base that they improved health and potentially lowered healthcare costs. By using a comprehensive evaluation that would further test this theory, and if benefits were shown through the evaluation to improve health and lower healthcare costs, then we would be able to continue offering them. And by using savings from our broader 1115 waiver to cover the costs of the Healthy Opportunities pilot. And so then we communicated the importance of HOP across the aisle more generally by one, the fact that it was a bipartisan initiative between the Trump and Cooper administrations originally, by focusing on the evidence that these benefits could improve health and lower costs, by purposely investing in the local community, by including local community-based organizations with a focus on minority and women-led community-based organizations. And then the fact that it was a pilot, that we were starting small, that we were testing the efficacy, and that we were improving it before scaling it statewide. So we went from negotiating our waiver and spent the first couple of years designing the program. So defining and pricing non-medical benefits, defining the program structure and various entities' roles and responsibilities. We included a new type of entity, the network lead, more commonly referred to as a community care hub. So we focused initially on defining their role and procuring this type of entity. Then we began operational design, so thinking about what systems we would use for screening and referral, for payment, encounters, provider enrollment, and we built, tested, and deployed these operational systems. At the same time, we were more clearly defining and communicating roles and responsibilities for our health plans and our providers, and developed and provided trainings for both the social care sector and the healthcare sector. We did conduct readiness reviews, which was not required by CMS, but I think really helped us to ensure that all of the different entities that were involved in this program were ready to go. And then after launch, we continued to meet regularly with all of our partners and have ongoing technical assistance and trainings, all entity convenings, and continue to make continuous program improvements based on feedback that we got. And I'm sure the department is still doing that today. So that's a recap.
Thank you. I really appreciate you sort of balancing the strategic and the technical, capturing the range of audiences. Really appreciate that. Seth, I wanted to turn over to you. So just a few months ago, you all released a really exciting interim evaluation reports, which is really important for continuing this program. So I wanted to give you some space to talk us through that. What were the big things you were seeing? And also, what did you learn about implementation factors that were influencing sort of some facilitators or barriers to results?
Yeah, thanks. And so the report that you allude to, there's a draft version posted on the DHHS website. I do want to put the important caveat out there that this is still under review by CMS, and so all the results are subject to change, and it is a draft right now. The main way we sort of thought about the evaluation is just kind of going step by step from what happens between identifying or having social needs or in factors that may impact health, and then actually seeing health outcomes. And so we kind of break those questions down. One, can we find can the state and the organizations who are running this running HOP can identify patients? Can they be enrolled? Can services get to them? Do those services improve the health-related social needs that they're trying to improve? And then does that lead to clinical and utilization and cost outcomes? And what we're finding, again, in the context of an interim report that's not as comprehensive as will be, is that there are a lot of signs of success here. We're finding, tens of thousands of people have been identified and enrolled and received services. Something like 90% of people who enroll actually get services. The services are, there's a whole structure around paying for them. Everything services are being paid for in a timely fashion, which is important for the sustainability of the program. The services themselves seem to be working to help reduce health-related social needs, and in particular, we found that in the absence of getting services, we really estimated that things would have gotten a lot worse for people, and these services both eliminate needs in some circumstances, but also, prevent things from getting worse too, which is another just component of what is being offered here. And then finally, the question is, what does that mean for, kind of clinical outcomes? What does that mean for healthcare utilization? What does that mean for cost? Clinical outcomes is probably the piece we know least about yet. We don't see any discouraging signs, but these were just places that we weren't able to analyze. But in terms of utilization and cost, we saw some promising signs as well. We saw lower emergency department visits for all HARP participants. We saw lower inpatient hospitalizations for adult HARP participants, who are the high group that has the most hospitalizations to observe. And because of this sort of decrease in kind of expensive or big ticket utilization, we estimated that even accounting for the cost of the services provided to people, we estimated that spending was lower, both medical and this direct service spending was lower in aggregate than we think would have happened in the absence of HOP. So that was very promising as well. I think it's also important to keep in mind, what the evaluation kind of big picture goals, I think people will, anytime you start talking about dollars and cents, people pay attention, but really the goal of the pilot is to improve health. And if improving health is what leads to changes in spending, that's great. But focus on health is really important. Also, this evaluation is a CMS sponsored evaluation, so focuses on the individual Medicaid beneficiary, and that is certainly very important. But there are a lot of other potential effects of HOP that are not the focus of our evaluation, but I think are also really important. Capacity building and strengthening networks within communities. As people are healthier, the contributions they can make to communities and all these other things. So even though, for me on the inside, the evaluation feels big and like we've got a lot of moving pieces and all this stuff, what we're looking at is really, I think, only a part of what is the true HOP effects might be.
Yeah, I really appreciate all the hard work too. It's really difficult to capture these effects, and just Seth is being modest, but there was a pretty large, in my opinion, and exciting cost savings calculation that came out of that interim evaluation report. I believe it was around $80 per person per month. So just wanted to highlight that for the audience. And a lot of this success is because of folks that are implementing this on the ground. So I wanted to turn to Tina. Tina, you lead Access East Incorporated, one of the 3 community care hubs, or as the program calls them, network leads running this program. Could you talk a little bit to some of your colleagues nationwide about what is a network lead? Who are Access East? How have you all succeeded communicating across different partners? And what has facilitated your success?
Yes, thank you, Will. Access East is actually run by Dr. Deborah Thompson, and it is a business that actually has 3 components. We have uninsured programs, managed care, and of course, we have healthy opportunities. And in that work, all of them combined, we are trying to make sure that people have access to medical service or healthcare services, that they have access to non-medical services, and that they're able to navigate the healthcare system, which is very complex, easily. And then, as has been said before, they're able to be healthier in living in the area, which allows them to contribute to the local economy. Access East, in addition to housing those programs, we also provide coaching to medical practices that want to become primary care medical homes. So it is a full package approach. Our role with Healthy Opportunities allows us to serve as the liaison between the Department of Health and Human Services, our prepaid health plans, and community-based organizations, which we call human service organizations in Healthy Opportunities. And through this network of HSOs, we are able to provide those non-medical services to eligible Medicaid members. But we know that the impact on the individual is a positive impact. That's just from the information that we're receiving. But we also have noticed the positive impact on the communities that are being served, especially the community-based organizations or HSOs. One of our organizations in particular, which they're all superstars in this work, but one organization in particular, Good Shepherd, which is located in rural Bertie County, a traditional farming community. The leader of that organization has not only been able to build and sustain the work of Healthy Opportunities, but she has also been able to incorporate the services of the local farmers and give them another outlet to sell their goods at fair market rate. So they're participating in this as well. So the growth in that community is being spread across all members of that community. The one thing that I think has made this work so successful is our ability to communicate and to do the tough work of truly collaborating with one another, because true collaboration is difficult. But when you have a group of willing participants who are committed to a common goal and able to work together to map out something that will work and enable us to serve Medicaid members successfully, that's a win-win every day. And this is very difficult work because it's uncharted territory, but together we're able to make, we've been able to make great strides in this space.
Right.
The other thing that also benefits Access East is that we have a good partnership with our local healthcare system, ECU Health. And that partnership allows us to assist the member even further, because sometimes they may, transition out of Healthy Opportunities or off of Medicaid. Having access to the resources within the health system because of our partnership with them enables us to assist that member even if they're not in Healthy Opportunities at that moment. They may cycle back in, but we're able to align them with other resources in the local communities so that they can still receive the services that they need.
I love that. It's a perfect transition to Crystal, speaking of working with the health system and working across lines of business. So Crystal, you are one of the HOP managers from the Healthy Blue perspective, but you also do a lot of other work with Blue Cross and Blue Shield of North Carolina. Could you talk just a little bit about how you're coordinating HOP work with your other lines of business and how you're leveraging your broader whole person health infrastructure?
Yeah, sure. So Healthy Opportunities has been a really exciting journey for us as far as whole health and health equity. A lot of times we do things piecemeal, but having Healthy Opportunities kind of convenes us all together so that we have access to these community-based organizations, these delegated care management entities, and our network leads who are really the drive behind everything. They're kind of keeping everything together with our community-based organizations. And at Blue Cross Blue Shield, we are committed to creating lasting impacts for a healthier future. So this aligns directly with what HOP, the mission is for HOP, right? So we're at Blue Cross, we've been dedicated to engaging and investing in our communities. One of the things that's really important is combating hunger, supporting local development, and enhancing equal access to healthcare. This commitment is bolstered by what's called our Extra Miles Tour. So if you've been in North Carolina, you've probably heard of our Extra Miles Tour, where our leaders have been able to visit all 100 counties and get in and talk to our community leaders and really understand where the needs are. And also to kind of collaborate and talk about how we solve those problems, right? Not coming in and solving them, but supporting those individuals and community-based organizations who are there in the community are already doing the good work. And because of this, we've been able to really impact these neighborhoods. And it's also made us stronger, I think, in the Healthy Opportunities pilot because we have those relationships. And we've been able to do innovative things with the Healthy Opportunities pilot, such as the Expedited Enrollment Initiative, which was with one of the HSOs, gave us a way to access healthy opportunities in a different way for over 2,500 members, and 500 of those were enrolled in traditional HOP, and we were able to serve over 4.6 million in fruit and vegetable prescriptions. So really exciting things.
That is wonderful, and I really appreciate the work that you all are doing to coordinate across programs as well, because that's really important. Just wanted to take the time. I know it's been rapid fire, but really want to thank our panelists, Amanda, Tina, Crystal, and Seth. And I want to kick it over to Michelle to launch into our second panel where we get to dive into housing.
Great, thank you so much, Will. As Will mentioned, this panel will be addressing the experiences, the challenges, the success stories of providing housing services through the Healthy Opportunities pilots. We're really happy today to be joined by service providers who will illuminate this part of HOP and to bring their experiences and perspectives to these questions. We have a short time for this panel, so I'm going to go ahead and introduce everybody all right now quickly, and then we'll move on to our content with the individual speakers. So first we have Sarah Rideout, and Sarah is the Healthy Opportunities Pilot Program Director at Community Care of the Lower Cape Fear. Next we have Kim Gore, who is the Chief Operations Officer at the Wilmington Area Rebuilding Ministry, WARM NC, which is a housing services provider in Wilmington. We have Madeline Morelli, who leads the statewide medical legal partnership program at Legal Aid of North Carolina. And we have Elizabeth Vernal with Atlantic Medical Management, which is a HOP care provider. So thank you to all our panelists for being here today. We're going to start with Sarah. I'll start with you. Can you tell us about the community care of the Lower Cape Fear? What are the unique demographic characteristics in your region that really have strong impacts on housing quality and availability? How has your experience with HOP uncovered a lot of those specific challenges in housing, and where have been the big wins that you've seen over the last couple of years?
Yeah, so absolutely. So Community Care of the Lower Cape Fear, we're a local 501c3 nonprofit that's actually served Southeastern North Carolina for over 21 years. We have a small dedicated team of registered nurses, care managers, social workers, pharmacists, health navigators, and of course our HOP staff. And we partner with ACOs and MCOs and other community partners in order to improve patient health outcomes, satisfaction, access to care, and connection to resources, really leading to improved quality of life and reduce healthcare costs. So that's really all of the work that we do, and Healthy Opportunities is certainly a big part of that. Our demographic is unique as to all the different areas in North Carolina, but we're made up of a 6-county region, mostly rural, but we do have suburban and urban areas as well. 4 of our counties are coastal, while 2 are inland. However, there are really some stark realities between economies, even within county lines. So we have a wealthier coastline with expensive new housing developments that are really aimed at bringing in affluent retirees and working families. And what we see there is then higher mortgages and rental rates and increased property taxes that really do affect a lot of the people and do lead to some displacement as well. And then as you kind of move inland, you begin to see more of an economic shift and increased poverty rates. So for example, you'll see older generational housing, as well as housing that is still damaged by previous hurricanes and flooding. So again, we are in an area where we do see a lot of flooding and hurricane damage. We have a low income housing supply. However, that is in very high demand. So we have some buildings in our region that have wait lists that are actually several years long. And that's really challenging, certainly, in HOP and not in HOP. So just some challenges, again, that we see. Again, when you think about the rural and urban communities when it comes to housing, in some of our rural areas, members may have difficulty when they're, if they have difficulty with housing, we do see that they're more likely to find a family member or a friend to stay with, because maybe the shelters or transitional housing isn't as available or common in some of those areas. And then again, we also see limited affordable, but here's the thing, affordable and safe housing, right? So that's the key thing is, is it affordable, but is it also safe? And so what we really see then in some of our more rural areas is that higher need for remediation and accessibility type services. And then I think a second challenge we see, and this is more in line with the actual work and healthy opportunities and in housing, is that those community-based organizations or CBOs providing those non-medical interventions, we call them services in HOP, they need to have access to funding to pay for the materials and to pay for the contractors. So HOP is a reimbursement model. So if, for example, we see any type of issue with reimbursement coming through, that may be a significant kink in the process for our organizations. I'm sure it's like this in several different places, probably no different, but a lot of community-based organizations don't necessarily have significant unrestricted funds on hand to keep projects going. So if there is a payment delay, that's going to be a real challenge. But with that said, oh, go ahead, Michelle.
Sarah, I'm just in the interest of time, I'm going to move on to our next panelist, but thank you so much for sharing the specific characteristics and a lot of the challenges that you're seeing in your area. Thanks so much for that. We're going to move to Kim next. And Kim, your organization, Warm NC, serves the Wilmington area, so it's a somewhat similar area to what Sarah was talking about. Can you talk about what you do at your organization, the services you provide, and how you've worked with HOP to do this? What successes and challenges have you seen in providing these services?
Oh, yes. Good morning and thank you. Warm NC, actually, we were started in 1996 and we were birthed out of disaster recovery. So speaking about Sarah and saying hurricane disaster and repair, we make rebuilds and repairs for individuals that can't afford it. We are a 501c3. We actually operate in all 6 counties that are currently under the HOP umbrella. And we do see the ruralness and issues with regards to not only repairs, but even ownership of the property, whether it's air property or not, that creates a difficulty for us. Also, with regards to HOP, it has opened an avenue of Medicaid and individuals and rentals, spaces that we have not been in before as far as rental and repairs. So we look at those as a win and a collaboration. What we are trying to avoid in this process is homelessness and preserving housing stock, since we have the affordability issue. We do mainly safety related repairs in the housing navigation space, remediation, as well as inspections. So it does keep us out in all 6 counties with regards to HOP. I like to also add stories about successes in the process. We had a HOP person in one of the rural counties. One of the other HSOs actually condemned the home when they did an inspection, but we went in behind that and we were able to do repairs from top to bottom with roof as well as flooring. This individual was actually living on her porch. The inside of the house was not livable. She was also cooking on her porch, as well as her 88-year-old mother was taking care of her. So these are the things that we have seen, and they're normal now in this process. We utilize the HOP services as well to bundle services. Since Warm's model is home repair and home ownership, HOP opened us up to the rental space. So we are able to address those issues. However, some of the challenges that we have with those issues are landlords obtaining permissions to go in and do the property, trying to ensure the landlord that we are not rent control, or that we are going to report them for bad services in the home. So that's one of the challenges. Another challenge is funding, having enough funds to do the work. What we're seeing in this issue is too much work to be done. So the actual amount that we have now allocated for services, in some cases, is not enough. So we either pick and choose of the safety element, or we say too much work and try to assist them. And lastly, it does assist us in bundling services. So if we do have a homeowner and the funds that we have under HOP is not enough to take care of them, we also qualify those individuals under warm traditional services. So in essence, it's a win. And at the end of it all, we are looking at preventing homelessness and again, preserving housing stock.
Great. Thanks so much, Kim. That sounds just amazing success stories. And I really appreciated how you reiterated the main goals of the organization and the ways that HOP is able to help you meet those goals. So thank you for that. I'm going to move to Madeline now. And Madeline, you run the Medical Legal Partnership Program at Legal Aid of North Carolina. Can you talk about how Legal Aid works with HOP, including addressing medical legal needs for your clients and the cross-domain services that are related closely to the provision of housing services in particular?
Yeah, I almost did it. I needed 10 seconds just to unmute. Thank you to NCIOM and Margolis for inviting me and for hosting this event. So I work for, as Michelle said, Legal Aid of North Carolina. We're a statewide nonprofit law firm. We serve all 100 counties in the state of North Carolina. We receive 400,000 requests a year for assistance. And HOP has played a really important role in helping us boost our capacity to meet the vast unmet legal needs, health-related legal needs for folks in our state. What our law firm does in general, I'm going to sort of frame it as the legal remedies to address this health-harming social needs or social drivers of health. So we as a law firm, we work in several areas. We focus on helping people access or remain in safe, affordable housing. We do a lot of work around family stability and safety, access to food assistance and other safety net programs, access to education, and access to economic opportunity. So HOP is part of our statewide law firm. We are, and it is an extension of our Medical Legal Partnership Program. And for those who don't know that term, it's an evidence-based integrated service delivery model. And there's, if anyone wants more information, I can point you that way. So it's like HOP, and it's been around for more than 15 years in our organization. It's closed loop referrals that count on an integrated, collaborative, team-based care kind of model with our clinical and now community-based providers, colleagues. So we provide linkages to health-related legal assistance. That is in North Carolina terms a cross-domain service. What that means is that we are providing services in 2 domains. So the goal of this service is to help people secure and maintain healthy and safe housing, and then also to mitigate and eliminate exposure to interpersonal violence and toxic stress. So here today, we're talking in this panel mostly about the housing related services. I want to explain a little bit about the service itself, and then I'll give examples of how closely the legal assistance connects with enhancing outcomes for other housing related services. So in North Carolina, this service is reimbursed on a fee-for-service basis. That's very important to us because it allows us, as the referral volume increases, to add capacity to our direct service team. So it's a really important payment methodology that allows us to grow as the HOP referrals grow. Currently, this service is limited in scope to advice and counsel. And what that means is that many people need more than that. They need, for example, help negotiating with the landlord. So the way the scope of service is limited here within HOP, it also creates a woodwork effect for us because we get access to more clients who need through HOP that need more than basic advice and counsel, and we have to rely on raising additional funds to provide that extended service. So here's the most important thing about that I want to say, because I'm a little worried on time. Okay. So how does this connect with other housing services? People who are referred to legal assistance, we can help prevent retaliatory evictions and unfair and unlawful loss of subsidy or eviction. We can help with people understand their rights and options around reasonable accommodations, how to retain the security deposit that they're entitled to if they have to move somewhere else. We can help people understand their rights and options with respect to repairs and services. To do this work, we have to collaborate very closely with our network lead, HSO, and care manager colleagues. And I apologize for going too long.
Thank you so much. That was extremely illuminating about all of those connections. Thank you, Madeline. Next, we're going to move to Beth. And Beth, you are with Atlantic Medical Management, and your organization plays the role of a care manager within the Healthy Opportunities pilot. Can you tell us a little bit about what that means to be a care manager, what your experience in that role has been? And also, can you talk about how care management for housing services in particular is by its nature more complex sometimes than being a care manager for other HOP services? Why is that? And what does that mean in terms of the challenges that you're facing in providing care management?
Yeah, so the role of the care manager is they're pretty much the coordinator for the client and the HSO. So what I do is I assess client needs, and as they're identified, I enroll them into the HOP program, and then I make referrals to the HSOs based on their need. And if an HSO would then find another need, then they would contact us and we would make a new referral for the client. So we're sort of that hub person that tries to make sure that the client has all the services that they need, and also work with the HSOs to assist them to get the services that they need. Housing case management is definitely one of the more complex programs in there, especially when you are dealing with a family that is homeless. There's not a lot of housing available for low housing. And because one of our counties is with a military base close, we find that the rents go up as the military pay goes up. So we're fighting those as well. And I think the biggest problem is it's on a tight timeline. When the person gets their application approved and get approved to move in, a lot of landlords want that payment done in 48 hours. But the way the program's set up, it has to go through the PHP to get approved, and then back to the HSO, and then they have to get the funds available. And so unfortunately, sometimes people miss out on housing if a landlord isn't willing to wait that time to get the payment of that. I think barriers for people are, they base it on their credit score, past evictions, monthly income, any criminal history. So I think for care managers, it's important to always be available because you're on that strict timeline, and know your HSOs well, so you know who can help you best for which client.
Thank you so much, Beth. And we've reached the end of our time for our panel, and I'm a little bummed about that because this was just such a fascinating conversation, and being able to hear from you all about the specific types of challenges that you're facing and all of the services that you're providing. So thank you for that, and thank you for all this great work that you're doing with the people in your areas. We've reached the end of our time, so great big thank you again to our panel for sharing these perspectives and experiences, and thank you for helping us learn the things that will help our state and for others joining from other states today looking to implement similar programs to help us improve the provision, payment, and sustainability of these services. I'm going to turn it over to Robert Saunders now, who's going to take us to our next panel.
Great, thanks, Michelle. And as Michelle said, I'm Rob Saunders, also with Margolis Institute here at Duke University. And I'm really pleased to be able to moderate this fireside chat with two distinguished state leaders here. One, Senator Ralph Hise, who represents the western part of the state, and also Jay Ludlam, who's a deputy secretary at the North Carolina Department of Health and Human Services, specifically focused on North Carolina Medicaid. And, we've heard a lot over this webinar looking at the past and the present of Healthy Opportunities pilots. And I think there's sort of 3 points here that are worth teeing up as we start this fireside chat. One is North Carolina is doing something new. We're doing something that no other state has done. And that means that we're still learning, that there are things that we discovered that worked and things that maybe we want to do a little bit differently as we look to the next phase. And we also, I think, have learned, and it's been indicated in the panel so far, just how much effort it takes to stand something up like this, and how much effort and capital it takes to be able to start something new, especially in the rural parts of our state, which may not have the same type of infrastructure that other parts of our state have. And we're also figuring out how to pay for all of this, mirroring the broader North Carolina Medicaid effort to think about how we pay for value. And so with all of that, would love to talk strategically with Senator Hise and Jay here, thinking about how we are moving forward and we will move forward Healthy Opportunities. So Senator Hise, maybe I'll start with you. You represent a rural district in the western part of the state. Would love to hear what you're hearing from your constituents. What are the things that are important to you as you're thinking through the next iteration of Healthy Opportunities pilots?
Well, thank you for the opportunity. I think we're really fortunate in Western North Carolina to have an 18 county region that can kind of serve in this pilot. That about half of that's in my district. And so I've seen a lot kind of come to the ground. The ability to have Dogwood Trust available to kind of invest funds to the startup before this began was huge to us as well. But one of the things we found, I see it as the tale of two stories. We have the Asheville, Hendersonville area who had what I see as a plethora of health service organizations and individuals in that. And then our rural communities in the far west and the northern mountains that quite literally didn't have health service organizations. The most you could put together is there may be a church involved in doing something or those, and there's so many restrictions with how the funds can be commingled and interlaced that it was a real challenge. And the most important part became not the reimbursement for the service, but the startup funds that were available in the process, which let us actually put some of those organizations together and establish them and use the ones that could participate in this model.
Thanks, Senator Hise. And Jay, maybe turning to you as we think start this conversation. I know you've thought a lot about learning from what we've done so far about what works and leveraging the interim evaluation to think through what the next phase might look like. And wanted to hear from you on your sort of perspective on what we've learned so far and what we want to carry forward.
Yeah, thank you, Robert. Appreciate the opportunity to be here. Since the beginning, we have, as part of the Healthy Opportunity pilots, we've had a desire to really learn and understand what is happening and then make rapid adjustments. And so we call it rapid cycle adjustments that we need to make. And Senator Hise raised an early one, which is we recognized early based on feedback that we did not have a model that reached those local churches and those local communities. And so we were able to make some adjustments early, and we need to continue to make those investments. But related to the interim evaluation results, there's so much promise, as Seth alluded to earlier. There's the promise of improving health. There's the promise of reducing the burdens and the struggles that people have to stay healthy or to stay engaged in community. And so we see that we heard Amanda talk about all those investments. So there's a real investment that we've made here. I think that as we move forward with the going in the future, I think that what we want to do is we want to build on those core successes. We want to think about how can we start to incorporate these savings into our Medicaid managed care model so that we can share those savings not only with the communities, but with the state itself, and start creating a total cost of care model that accounts for all the pressures, whether they're healthcare related or social risk related, that affect the health of an individual, and then create that sustainability model.
Thanks, Jay. And really, Senator Heiss, this brings up a point that I think you may want to consider and that you've been thinking about, which is what would be the future way of supporting some of the way that HOP has been funded. So right now we have a fee schedule, which is first in the nation. We did that for very specific reasons, but that may need to look a little bit different in the future. I wanted to hear if you've had thoughts in that regard.
Well, the interesting thing is that in all of Medicaid, this kind of fee schedule is what we've been trying to get away from. That we got out in the healthcare industry, that we're no longer paying for the number of x-rays or the number of services provided, but we're actually paying for the outcomes, and that we can convert the entire managed care system that allowed these funds to be created is based on moving to paying a per member per month to the 5 PHPs in the state. And the savings on that is where this funding is really coming from. So as I see healthy opportunities going forward, we've really got to find ways to convert that payment model to per member per month payments with bonuses for the actual outcomes we're looking for.
Mm-hmm.
So when you're improving the health of individuals, when you're doing and you're showing that, that's the bonus, that's the reward in the system. And those initial upfront payments allow you to create a network because of what it will return to the system. Yet I'm proud that we were first nation to scan a box of food and to have those funds be able to be proportionally out to the organizations and everything else. But that literally is the concept we are moving away from in all of healthcare and trying to get to those bundle payment models. And I just don't see that healthy opportunities will be any different.
And Jay, and being mindful of time here, we only have a couple minutes left. And so I would be remiss if we didn't talk about the future. And Jay, I know you are intimately involved right now and thinking about the future. You can't share everything right now because it's still negotiations, but to the extent you can share where the future might look, would I think that would be helpful for this webinar.
Yeah, for those of you who don't know, we are in the process right now of negotiating with CMS on an amended 1115 waiver to bring healthy opportunities statewide. And I think this points to a very important inflection moment that we're in as we move to that statewide profile. So I anticipate around the end of September, maybe to mid-October, that we should get approval for the 1115 waiver. The negotiations, of course, get very intense when everybody has to actually sign the document. And so things are coming out right now between both parties that we're making sure that we negotiate the best deal for North Carolina. But it goes to how do we build on those strengths that we've talked about earlier? And how do we make the adjustments that Senator Heiss is referring to? And how do we create a sustainability model too that allows us to scale up? Currently we do have pressures in our current allocations that we're trying to work through, and I think we're going to get there. But this is going to be a big investment on the part of the state, but the right investment. And I think it's the right investment because not only are we addressing the health of an individual, we're also addressing the local economy, those positive community impacts that Tina was talking about. There is a real uniqueness to the model that we've designed here in North Carolina that it may sound a little corny. I can start to feel it all working together. Medicaid managed care, healthy opportunities, expansion with the new 1115 waiver, wider eligibility, hopefully for pregnant women, so that they can qualify very quickly and get into the program. Supporting foster youth, supporting individuals who are being released from incarcerated settings. Like all of these things are starting to work together. And I think we're at this important inflection point regarding how far does North Carolina want to go with this.
Great. Well, Senator Hayes and Jay, I know both of you have a lot of demands in your time, so thank you for taking the time to join us today, and really appreciate your thoughts here strategically on where healthy opportunities might go. So thank you.
Appreciate it.
Thank you.
Thank you.
And now actually we're going to shift gears. So moving from this fireside chat, we're able to talk strategically about where healthy opportunities might go and really look at what that might mean on the ground. And so I want to call up three panelists who have done a lot of really important work in both implementing healthy opportunities now and working in other types of social needs work in North Carolina now. I want to call Matthew Dolge, Laurie Stradley, and Paul Sweepson to the panel and get everybody online. But really some of the key things that we just talked about here are that we are looking at the next iteration of healthy opportunities, which may take things statewide, may build on what we've learned, what worked, maybe what didn't work the first time, and may think about how there may be some different ways that we help support healthy opportunities. And I think what Senator Hayes and Jay flagged was, again, this is the first time we've done something like this. It takes a lot to stand up and build capacity, especially in the rural parts of our state. And there's still things that we may want to solve in the future. So maybe, Laurie, starting with you, would love to have maybe you start here talking a little bit about the work that you've done so far, the unique context that you're seeing here and what that means for the future.
Thank you, Rob, and all of those who've been participating. I've been grabbing bits and pieces of everything you've said. Impact Health had the unique opportunity to start up as a part of the Healthy Opportunities pilot. We did not exist before that, which means that we could build our organization to be explicitly reactive to the way that this pilot set up, and also allows us to be nimble and responsive. And we were able to, one of my favorite things about this pilot is that mix of innovation and engagement with existing resources in the community. So we have some great organizations out here in Western North Carolina that were ready from day one, but still needed quite a bit of support. It is one thing to deliver social health services to those in need with grant funding. It is another to effectively become a Medicaid provider. So we've had that chance to build those bridges and support. And from day one, Impact Health has felt the weight and the opportunity that comes with being a part of this pilot, which means everything we do with an eye on the future and an eye on the agencies that will try to do this as well. And right now, there are over 20 waivers, I believe, that include using Medicaid dollars to invest in social health care. So Impact Health is trying to create tools and resources to shorten the runway, reduce the cost, and make it easier for other agencies here in North Carolina and around the country to become community health hubs that support this work. And one of those pieces is also allowing us to think about how we can leverage these investments, braid them together with public and private funding sources to ensure that the structures, the learnings that we've built together can be used to support others. We know the need is greater than the Medicaid eligibility. We know there are folks with private insurance, with Medicare, with no insurance, even with the expansion, that could benefit from these and lower the overall healthcare cost burden to our healthcare system. And so we are in the process of launching a clinically integrated network that focuses on social care integration. And so we're really excited about, we're confident that we wouldn't be able to do this as quickly without the public-private relationships that came together to make healthy opportunities happen.
Thanks, Laurie. And I think you're also noting here that we want to build something long-lasting that lasts more than just an initial pilot. And I think this also is a nice transition to Paula. Paula, one of the goals of Healthy Opportunities here is to make health and healthcare better for all North Carolinians. And so to make sure that we are reaching people that may not have been well served before the pilots. And so we'll welcome your thoughts about ways that the pilots have been able to leverage and reduce disparities, but what it can do more to make healthcare better and health better for all North Carolinians.
Yes, I can say one thing I've heard while I'm doing this work is people want to hear from the community. And what I found is they want to hear good stuff. They don't want to hear, the controversial stuff. So I'm a Impact Health Board member, and I give a shout out to Laurie. I was wondering, being from a community organization, what did I know about being on this board? And she said, we need community. We need to hear the voice. We need to have the ears up to see what they're saying. So my organization, West Marion Incorporated, we host community forums, and we get the voice and the ear of community to spread some of the resources that they haven't always been privy to. And so as I think about how we have been able to do the things as far as with the healthy opportunity pilots, if it wasn't for community and organizations like in McDowell County, like Match, it's a resource connector. So you have to have people that are boots on the ground who are doing the work continually. And, we live and breathe community every day. So this is what's getting the word out more. And one thing I'll say, just one of the biggest challenges I'm seeing right now is the I say the demonizing of DEI. I hate to say that word, but diversity, equity, inclusion. If you look at who's on these panels today and the people on the webinars, we're a diverse group of people who have different ideas and lived experiences. So how can we get everyone to understand that DEI is not from the devil, being from the Bible bed? DEI is how we can look out for those who haven't always had the chance, because they don't know what they don't know. We know broadband, that is an equity issue. So if we can get, our leaders to understand that everybody needs something, and how can we just make sure everybody gets what they need, and only thing, not just what they want.
Yeah. And Paul, I think you bring up several really important points here, which is as we're looking at expanding Hub, it is really important that we make sure we're bringing in the voice of the community and into the way that is being done, and that we're making sure that we're building local capacity and leveraging the community organizations that are there in North Carolina, and that we're building local capacity, drawing on the good work that you and other colleagues of yours have done as well. And Matthew, you're going to have the final word here. So you are Community Care Hub thinking about what participation in the pilots might look like in the future as you expand. Would love to hear those thoughts here and based off of what you've heard throughout the last hour.
Yeah, thank you. That's very exciting. I'm from PTRC, which is a membership organization of 77 local governments. We weren't included in the first round as a lead entity, but continued to grow our capabilities around the Community Care Hub with contracts with private insurers, partnerships with hospital systems and ACOs, using health workers for case management and navigation, and then also been re-engaged on this federal thriving matrix, which is being pushed down from the federal government. We hope to have a role moving forward in healthy opportunities, but we think in order for that to be healthy, I think just what Lori was talking about, we see it as a part of a portfolio rather than being a standalone. And so we see that being tied with Medicaid, Medicare, private pay, and community resources to kind of blend and braid resources to support that backbone. We think the 4 strategies and categories that Healthy Opportunities deals with are largely on an emergency level. And we think that the thriving categories, which add things like meaningful work, personal wealth generation, education, that if we can also engage in those, then we build more personal resiliency to folks as they move forward past those emergency needs. I'd like to really applaud the state on, I think, a good evolution through 3.5 or 4 years around things like point of contact enrollment rather than enrollment from the top down, and flexibility around things like healthy home goods to meet folks where they are with immediate needs. I think the challenge will be being additive to CBOs and helping them build long-term extended capacity rather than being stressful. And I think the keys to that from our perspective are, I think, as Senator Hayes talked about, being priced appropriately and having some long-term goal from a pricing standpoint. And as Sarah talked about earlier, I think cash flow, which we've heard is a major problem, and most of our CBOs, especially the smaller ones, can't front cost for 4 months. And so it's figuring out how to fix cash flow to help those folks rather than, again, be a stress. I really think that an answer for that is quite frankly to use lead entities that are very robust to front load some payments on claims and then allow them to reconcile with the insurance carriers and then and be between those providers and the insurance carriers in reconciling those so that, again, like Beth talked about with housing, you can have some money injected in the system quickly and support those CBOs quickly so that they aren't extended from a funding standpoint. And then also we've heard stresses on folks tracking payments. And if you do that through a lead entity, it takes away some of the need for each individual small CBO to really build a huge financial staff that costs a lot of money for them to do. So again, great stuff happening. We're excited about it. And we think that a few tweaks are really going to take it over the top.
Well, thank you, Matthew, Paula, and Laurie. I know we could have spent probably the whole hour just on this panel, and appreciate your being able to share, your on-the-ground experience and how that may look in the future. I want to turn things back over to my colleague, Will Blesser, who's going to close us out for today.
Thanks, Rob. And again, thanks to all the panelists. 60 minutes, 13 speakers, 3 moderators. I can't believe we pulled it off. So really appreciate everyone tuning in. Just a couple things I wanted to flag. Again, the paper that we released, the Community Action and Analysis Plan, that is meant for community care hubs like many of the speakers we heard from today, to start as a resource for them to scale or expand or build new partnerships with the health system. So please do read that. In 4 to 6 weeks, we're crossing our fingers, as Jay pointed out, to hear about the Healthy Opportunities Pilots extension and expansion. And then finally, I just wanted to note a huge thanks to the KP Reynolds Charitable Trust. They have supported us throughout this work, which has been really critical, and they've supported many of the partners today. So thank you very much again, everyone, for tuning in, and we look forward to talking with you in the future.